Welcome, everybody, to the Alaska Stroke Coalition and RapidAI Virtual Symposium about elevating stroke care in rural and remote communities. My name is Carolina Meyer, VP of Clinical Affairs at RapidAI, and I will be your host today. So let's get started now. Kicking us off, Dr. Lucy He. Please, Lucy, go ahead.
Thank you for that kind introduction, and thank you everyone for participating, and to the executive team of the Alaska Stroke Coalition, to all of our stakeholders here in the state, and also to Rapid, who's been our both technical and also imaging partner, and also the LEQ Foundation for their generous grant. So just to start things off, we have a couple of updates in terms of neurointerventionalists. And so obviously I've been here for a while. Dr. Jennifer Sokolowski joined us about 2 years ago. And then more recently, this past fall, Dr. Brent Morrell started. And so now for the state, we have 3 full-time neurointerventionalists. Dr. Morrell comes to us from the University of Denver in Colorado. He just finished his neurointerventional training there. I believe he was also a resident there and did his vascular neurology fellowship as well. And so we're very excited to have Brent join us, and so offering some improved coverage from a call standpoint, which Jennifer and I are grateful for, and we look forward to having him work with everybody as well. We continue to have a stable cohort of locums neurointerventionalists, and so Dr. Blaise Baxter and Dr. Tony Bell have been up periodically and consistently. And as far as a locums coverage standpoint, this has been a stable cohort for us, and so many of you, I think, have transferred patients and discussed with them, and so they will remain as well. One person that I wanted to mention that unfortunately I forgot to put a slide together for was for Dr. Shruti Fadnis. She joins the Alaska Stroke Coalition as a research fellow this past year. She comes to us, from India, and has been instrumental in helping to put together a lot of the data sets and things like that for us to actually start being able to cull through all the data that we've generated since this project began, and it's been instrumental in helping us getting things moving. So to move on from that, this slide I think is a familiar one to all of us here in Alaska. Alaska geographically is one of the largest states in the union. However, while our overall population is not very high, we have less than 750,000 full-time people here. Our population does swell to upwards of 3 to 4 million people during the summertime, secondary to tourism. We have very limited capabilities when it comes to hospitals, especially hospitals that are able to take care of complex strokes. The state now has 2 comprehensive stroke centers, Providence, Alaska Medical Center, and also Alaska Regional Medical Center, both here in Anchorage. Primary Stroke Center is also Mat-Su Regional. Because of this, we have 2 stroke thrombectomy capable hospitals, but also these same 2 CSC hospitals are capable of dealing with complex other cerebrovascular things such as aneurysms, AVMs, and things like that. Secondary to this geographic limitation, the fact that greater than 50% of our population is spread out outside of the Anchorage Bowl area, identification of strokes and getting them these patients to the right places for the right interventions is very important. As we know, about 20% of ischemic strokes are large vessel occlusions. A lot of times these patients present outside of that 4.5-hour time window to qualify for thrombolytics, and these are the patients where truly their only intervention, if we can get them to it, is for stroke intervention and thrombectomy. In Alaska, we identified that one of the greatest limiting factors to being able to get these patients to stroke intervention was an imaging transfer issue. We know that stroke intervention works when you compare the data from the original stroke thrombectomy trials. The numbers needed to treat to have a good outcome compared to the cardiac intervention data is much less. But despite this, our image transfer remained the largest issue. Particularly transferring a full CT angiogram from one hospital to the other takes almost 45 minutes. And that's not counting the additional time it took for the patient to obtain the imaging, for a local radiologist to read it, and then get back to the local physician in the ER that the patient did indeed have an LVO. And so to address this, we worked to identify additional technology already available, and that's how Rapid became a partner for us. They have the ability to essentially have hospitals push a subset of their images into the cloud, and the cloud will then redistribute the images, notify, and also allow interventionalists here in Anchorage to see what's going on, thus significantly cutting down time for both the identification and review of the images, and also more importantly, AI technology to help us look at things like CT perfusion and also auto LVO detection. And so with this in mind, we wanted to create what was called the Rapid Alaska Initiative. And so for 3 years, we obtained external funding to be able to provide RapidAI across the state at 6 different hospitals. Since then, South Peninsula Hospital in Homer is also joined on, not independently from a funding source. And the goal was basically to reduce unnecessary transfers, reduce time to identification of thrombectomy or LVO patients to get them here, and overall improve the care of stroke for all Alaskans. And so we're about midway through our grant cycle. In year one, some of the highlights was obviously the implementation of Rapid across these different hospitals does take quite a bit of technology buy-in and help getting protocols set up and whatnot. With the implementation of Rapid across the state, we also asked that these hospitals participate and get with the guidelines and start providing additional stroke data. This finally allows the state to have a larger statewide registry for at least ischemic stroke patients. We have bi-monthly coalition meetings at an ungodly hour of, I believe, 6 a.m., which is my fault. And then along with this, we started to see some early improvements in transfer decision times. More importantly, I think that the initiation of all of this and happening and coalescing at around the same time really helped to push the discussion of stroke, and having everybody from outside hospitals, clinics, PCP providers, EMS, medevac, everybody coming to the table to discuss both cases, things that were problems, and trying to figure out a solution altogether, I think has been really helpful for us. Year two, which is what we're in right now, is that processing and obtaining successful RapidAI scans across the hospitals, ensuring that the cloud-based platform is working the way it's intended to, trying to work to protocolize imaging at all the hospitals so that it is automated, and in the background the stroke imaging will reach the server, as opposed to something that a human has to manually consider and think. And what we mean by this is, if the physician didn't order it exactly as a stroke, or if the stroke alert wasn't called overhead to CT, that these images still manage to reach the server, as opposed to someone having to manually make that decision. And with it, attempt to get better LVO thrombectomy hit rates, faster decision times, and reduce unnecessary transfers. And so some of the data from the initial Get With The Guidelines call, you can see that this is AHA STR 13, which is time to IV thrombolytic therapy within 60 minutes. We did pretty well in 2023, saw a small drop off in 2024, and the numbers are starting to rebound in terms of the percentage in 2025. A lot of this is to be expected. We had a lot of discussion about IV thrombolytics and time and protocols and things like that. And I think a lot of hospitals, and then reassessing and reviewing what they were doing, needed to make some protocol changes, especially with this advanced imaging that's now available. A lot of hospitals changed some of their protocols, and with any new protocol change or implementation, you're going to see a little bit of a lag in terms of efficiency. This mirrors basically the prior slide. This is now IV thrombolytics for patients that arrive within 3.5 hours and get treated within 4.5 hours. The EMS pre-notification, this is an interesting trend. Historically, at least from what's reported to Get With The Guidelines, EMS pre-notification for potential stroke patients still is just at around 60%. I know that Mike Levy down here in Anchorage is very much wants to increase this, and also provide additional training for his staff to potentially identify large vessel occlusions in the field. There are a number of pre-hospital screening things, Cincinnati, LAMS, the VAM plus score that can be used. And the idea here is that, we want to teach our, first responders signs and symptoms of a stroke to pre-notify hospitals so that everyone can be ready. CT is ready. Everyone is sort of, it's kind of like, any play in sports. You're ready to execute once the patient arrives. But in particular, patients that may be demonstrating very significant neurologic deficits or stroke symptoms, if we can identify these patients early, the goal and the hope is that with this early identification, it means that everything that happens once the patient reaches the hospital becomes faster as well. One of the things that's always been brought up is just exactly how accurate, is the in real world training when we apply these pre-hospital screening things. And the answer to that is it is variable. It's probably not as good as what's reported in the literature. However, I think moving forward with this and collecting the data, which I know that AFD wants to do, I think will be important. And I think will also probably help to streamline some of these other metrics that we'll talk about next. So this is something that I think is directly related to EMS pre-notification, which is this concept of door-to-device times. So these are actually two metrics put together. So the American Heart Association measures door-to-device for within 60 minutes for patients that transfer from an outside hospital, and then within 90 minutes for patients that present directly, to the ER. And what I want to highlight here is this is actually something, especially for the patients that are coming in from an outside facility, we should be able to get this metric down significantly. I think if we know that EMS is bringing in a patient that is not just a potential stroke alert, but also a potential LVO, and we know that the sensitivity and specificity is good, I think we can probably pre-notify our cath lab teams and our ER teams to be on standby so that we can further decrease this. Within the hospital, once the patient arrives, I think that most ERs and the imaging protocols are pretty streamlined. They're pretty efficient to try to get at least the imaging done within the first 20 to 25 minutes. The lag time is usually then us trying to find personnel to get the cath lab set up, find an anesthesiologist, figure out, are our cath labs encumbered and things like that. And with our transfer patients, we've noticed that we can pre-notify, we can have the cath lab come in early, we can tell anesthesia ahead of time. And so all these things are helpful, but still, I think that this number can be much closer to 60% or 70%. One of the things that we had talked about early on was, trying to see if we can improve our door in, door out times. And for the longest time, it looked like we weren't making that much progress. But the reality of it is that we really are. I think we had set an internal goal, I would say, about a year and a half ago, of trying to get this DIDO time to about 25%, meaning that the patient, that presents to the outside hospital, that they are, that they get to the ER, worked up, given whatever interventions they qualify for, and then out the door in less than 90 minutes. There's a whole host of things that go into this, between is transport available and, things like that. But you can see that we've had incremental improvement, in these DIDO times. And that says a lot about, I think, just bringing our medevac partners and other medical transport partners to the field. Things that we're doing quite well in, statin therapy. So something to be very happy about. And also VTE prophylaxis for patients once they're admitted with an ischemic stroke. One of the other things is that, at least just within, the last couple of years, you can see that the number of transfers to comprehensive stroke centers has, had a significant increase. This isn't just that we're sending more patients, to Anchorage. It's also just that we're identifying more frequently patients that have, intervenable things, so LVOs, but also patients who qualify for IV thrombolytics. Many of the hospitals outside the Anchorage, while they have CT and are capable of providing IV thrombolytics, don't have the capability of monitoring these patients afterwards. And so, the increase is secondary to just a better global understanding, workflow, and identification of all ischemic stroke patients. You can see that median door in, door out times, it's not just that we're meeting the 90, but the numbers are starting to come down as well. The blip in 2024 is not surprising. We had a significant jump in the number of patients that actually transferred for thrombectomy. And so with that, we're going to see some growing pains in terms of protocols and things like that. And so 2022, 2023 to 2024, we saw a significant rise in the number of thrombectomies. And these are just the patients that were identified as LVOs outside, arrived here in Anchorage, had repeat imaging if appropriate, and were still deemed to be candidates for stroke intervention. And again, one of the things that's been supremely helpful for us as interventionalists is that, especially now that CT perfusion is available at all the rapid sites, having a perfusion done locally, even if the patient has to have repeat imaging when they arrive in Anchorage, when we compare those two perfusion scans, we're looking to see just how much change there has been in terms of the ischemic core, compared to the penumbra. And that's really helpful for us to figure out, does this patient, are they rapidly progressing in a way where intervention is unlikely to benefit, or despite, the large stroke and the time that's already been had for the patient's brain, is there still significant salvageable, territory and whatnot. And so for us, as interventionalists, perfusion is very important. And I also think that it seems counterintuitive, but the smaller the hospital, the longer the distance the patient has to reach in order to get to intervention, the more important CT perfusion is. It is truly then becomes a very important both screening tool, identification tool, and inclusion or exclusion tool for us. And I think it provides the fastest, triage for stroke patients in that situation. More importantly, we have a large swath of the population here in Alaska that are Alaska Natives. And for the longest time, we know that there are certain vasculopathies and arterial diseases that are unique and in higher prevalence, things like moya, vasculitis, Takayasu's, and things like that. And so capturing and being able to provide improved stroke care to this part of the population is very important as well. And as you can see, we're seeing a significant increase in the number of patients identified with stroke in this population. And then the roll composite measure. This is something that is very unique. Almost every hospital outside the Anchorage Bowl area qualifies as a critical access or rural care hospital. And so to see these metrics significantly improve over the years is very, very, impressive. These are hospitals that, probably don't see a very large volume of stroke care patients, but at the same time, the patients that do come there, getting them timely care, access to, IV thrombolytics, getting them imaging done, and all these things is very, very important. And again, your first point of contact is really where you can make the greatest impact, in my opinion, about what happens next in the overall course of this patient's stroke journey and their recovery and intervention. So this is a huge kudos to all of our hospitals here in the state. So far, we've been working on trying to protocolize and automate a lot of the imaging acquisition when it comes to stroke, using cloud-based platforms and next-gen imaging with Rapid across sites within the state. CT perfusion where feasible across the state, and again, I think CT perfusion is more important for our smaller hospitals than it is even for the larger ones, especially from a stroke triage identification standpoint. The door in, door out metric, while we do see improvement, and certainly our times are starting to go down, and our DIDO within 90 minutes is going up. This is a very complex metric to measure, and especially in a state where we have the majority of our transfers are by fixed wing or helicopter. And I think that looking at things like door to decision and imaging to callback is probably a better measure of how we're doing. And more importantly, our collaboration is stronger than ever across the state to try to improve these things. Future goals for year 3, legislation. So right now, trauma is the only sort of legislatively mandated and recognized emergency. HB 27, I think, is the most recent name for this bill, but it would hope to recognize STEMI, stroke, and trauma as time-sensitive emergencies by the state, and within that would hopefully allot money to the Department of Health to then be able to track this, and then also throw additional resources to better understand how we're doing, and also mandate them that we track what our outcomes look like and whatnot. This has been ongoing for the last 2 years in the state legislature. Most recently, I think in May, it went to the I want to say the Finance and Health and Science committees for further evaluation. Direct EMS field to Anchorage for VAM positive or LVO patients. This is something that is being done in and around the Kenai Peninsula. We set a protocol for this, and it's been in effect, I think, since the end of February. We've had a handful of patients come through already. What we're tracking is both the times and also looking at how accurate, how sensitive and specific is the in-field LVO detection. Our next step is to improve overall community education. I think, we've worked a lot about inpatient ER identification and in-hospital stroke protocols, but one of the pillars of the Alaska Stroke Coalition is also prevention. I think prevention and education really starts out in our communities, and so we're going to work with some of our industry partners about that, and then work on, figuring out how to make these changes and this platform that we've implemented sustainable for the long term in the future.